Thank you very much for joining me today. I'm Carole Florman. I'm a policy fellow for CancerCare. This is going to be a short presentation, just about 15 minutes, and we'll be happy to take questions at the end. So the best thing to do is to just put them into the chat box, and then we'll get to those at the end. So a little bit about CancerCare. We are a 78-year-old nonprofit organization that provides no-cost services to anyone impacted by cancer. This slide shows our direct impact in fiscal year 2021. You'll see how many people we've served and the types of services that we offer. We don't endorse specific treatments, drugs, facilities, clinicians. Our only goal is to help people impacted by cancer in any way that we can. Now, today we're really talking about employee health benefits and sort of, the problems, the good, the bad, the ugly. And it's really hard, we know, for the managers that are charged with developing a range of health benefits. There are a lot of things that have to be considered, and they have to balance the increasing costs of healthcare and insurance plans with the needs of employees. Some of the considerations include the cost of the plan, and that's whether paying insurance premiums or, if self-insured, fixed and variable costs. What types of plans to offer to employees, whether that's a PPO plan, HDHPs, HDHP with HSAs, there's lots of options. The networks include the clinicians and the facilities that will be covered or will have a preferred agreement with. Formularies are the drugs that will be covered or excluded by a plan. And for each of these drugs, the cost share that patients will be responsible for. The plan policies are the exclusions, the rules, utilization management policies that govern access to treatments. But what employers often don't consider is how their benefit design might impact an employee's decision to follow or abandon a treatment plan that's laid out by their physician. This is what we call treatment adherence, and it can make an enormous difference to the health of employees and greatly impact employers. Now, we hear a lot about, let me go back. We hear a lot about the cost of prescription drugs, but the question about treatment adherence that I'm going to ask is as it applies to prescription medicine. And I've given you the spoiler, but I'm going to still ask, what percentage of prescription drugs are not taken as directed? And we're going to have a polling option. So is it 10%, 35%, 50%, or 60%? All right, well, we've got a couple of different answers. We've got share our results. And so as you see, we had most people thinking it's 50%, a few thinking it's actually 35%. The real answer is 50%. Now, to a patient, the costs of non-adherence may come as a progression or a worsening of their disease or their condition. But to employers, the costs can be manifested as increased medical expenses, as well as absenteeism, lost productivity, decreased satisfaction, and even lower retention. And the costs of non-adherence are estimated to cost the U.S. economy between $100 and $290 billion, that's with a B, a year. But adherence to medication can be improved. This slide shows an example from the Integrated Benefits Institute about how increasing medication adherence by employees with a chronic condition, in this case diabetes, can reduce absenteeism and save money. Now, the ways in which you design your benefits can decrease or improve adherence. There are a number of causes of non-adherence. Let's see. And some can be addressed by benefit design, and others reflect different challenges. So cost. Cost is an enormous factor in whether people adhere to treatment. There's a direct and measurable correlation between a patient's out-of-pocket cost for a prescription and the rate at which it's abandoned. A $10.40 increase in an out-of-pocket costs can really lead to a big decrease in usage. Now, this is, pretty dire, but when you have people with these chronic conditions, cost is the most common reason that they might abandon their treatment. Administrative burdens include things like prior authorization, where the pharmacy has to request permission from the insurer to fill the prescription. Formulary exceptions, where the patient needs special permission to get a prescribed drug that isn't on the formulary list. Or step therapy, where a patient must try one or a series of other drugs and have those drugs fail before being given the drug that their doctor prescribed. Now, the AMA, that's the American Medical Association, does an annual poll of their physicians, and they found that 82% of physicians reported that prior authorization has led to their patients abandoning treatment. Complexity of medication. Now, this could be a number of things. It might be the form of the drug, say, having to mix a powder into 8 ounces of liquid multiple times a day rather than taking 1 or 2 pills a day. Or it could be a drug that causes side effects that need other drugs to manage those side effects. Then we have things like side effects and personal social factors, and those are issues not really created by benefit design and can include a range of reasons, including misunderstandings of the treatment, personal beliefs, illiteracy, lack of pharmacy access, or incapacity. Now, today we're really focusing on the elements of benefit design that can be controlled by companies that can contribute to non-adherence, in particular, out-of-pocket costs. As out-of-pocket costs rise, adherence goes down. Only 5% of prescriptions are left at the pharmacy if it's a zero copay. But if the copay goes to $125, the abandonment rate is 45%. And when the out-of-pocket cost is over $500, which is not uncommon in diseases like cancer, abandonment can increase to 60%. Now, Americans, even those with good health insurance, are facing a crisis of medical debt. And you'll see the numbers here, are really quite stark at how many people have medical debt. And good benefit design needs to consider all the additional out-of-pocket expenses that sick patients face and work to hold those down so they can control things like deductibles, copays, and coinsurance, because sick patients are also dealing with things like transportation, maybe a special diet. Perhaps they have to take time off work. Now, CancerCare looked at these issues a few years ago, and we found that more than a third of cancer patients take steps to reduce their costs, including not filling prescriptions, skipping doses, or cutting pills in half. This is a short video featuring a real patient, Rita Anderson, who is a stage 3 breast cancer patient, and she was forced to delay her cancer treatment due to the high out-of-pocket costs of her treatment. And those costs were dictated by her company's benefit design.
In the following story, you'll hear about how financial non-adherence can affect patients.
So in March of 2020, I received my diagnosis that I had breast cancer. My oncologist prescribed my oral chemo medication, and my pharmacy called me and said, your out-of-pocket cost is $3,005. I called my insurance company, and I let my insurance company know my situation. I told them I don't have $3,005 for my medication. And they said, unfortunately, Miss Anderson, there's nothing we can do. That's your insurance policy. We have to adhere to it. And you need to come up with the $3,005 if you want your medication. So I had to do without my medication for 71 days. I also finally had my mammogram and ultrasound 2 weeks ago. And unfortunately for me, I have to do a biopsy tomorrow because they found something. So I don't know if it's because I went without my medication for 71 days. I just want insurance companies to know that patients want to live. I think it starts with your employer finding the right insurance companies for their employees.
In the following story, you'll hear about how
CancerCare has created a toolkit for employers to help address the problems that you just heard about from Rita Anderson and the problems that we hear about from our clients with cancer. Now, we know that these same problems are experienced by most people who have chronic or serious diseases, and that can include anything from diabetes to kidney disease to cancer to people whose kids might have cystic fibrosis. Now, we believe that a holistic, nuanced approach to benefit design can help patients and employers. Self-funded employers in particular have the power to design benefit plans that better balance the needs of patients and the cost of benefits. But to do so, they really need to understand the unintended consequences of utilization management practices and how those practices can be made more patient-friendly and cost-effective. There are a number of things that companies can do to help increase medication adherence. Most importantly is looking for ways to keep out-of-pocket costs low. And this could be by offering just co-pays instead of co-insurance on formularies. Also covering generics. You'd be surprised at how many formularies actually don't include generics and force people to take the brand name drug. And even if the copay is low, that ends up costing the system and the employer a lot more money. Very often that's because of a large rebate that's being paid to the pharmacy benefit manager. Allowing patients to remain on treatments where they're clinically stable is so important. When people are forced to change a drug that's working for them and try something new, they're much more likely to become non-adherent. And allow employees to choose any in-network pharmacy. Forcing patients to necessarily use a mail order pharmacy can lead to delays, can lead to problems, and can lead to non-adherence. There are other policies that can increase non-adherence and really should be avoided. And one is, of course, requiring high out-of-pocket costs for employees. Having time-consuming administrative burdens. Again, these are things like unnecessary pre-authorization or step therapy. Now, there are places where those practices might be appropriate, but in managing chronic conditions or serious illnesses like cancer, they are not helpful and, again, can really lead to very costly and destructive non-adherence. Forcing to change treatments for non-medical reason. This is called non-medical switching. And again, this is when there's a formulary change that would force a patient that's stable on a drug to switch to another drug because the PBM is either getting a higher rebate or for some other reason has decided to just stop covering that drug. Requiring the use of mail order pharmacies can be a problem. I actually know a young man who recently had a 2-week non-adherent episode because his medication that he needs to take was shipped late. It sat on a runway with FedEx for over a weekend, non-refrigerated, and he had to start all over again and get it again from the manufacturer. And that's because he had to use a specialty pharmacy mail order rather than being able to go to a local pharmacy to get the drug that he needed. And then, of course, basing formularies on rebates and PBM profits instead of basing them on clinical outcomes and cost. This, again, happens a lot more often than you might think, and it's a really destructive way to set up a formulary, and it's bad for employers, bad for employees, and really bad for the health system. And now I'd be happy to take any questions that you have. If you could put those into the chat box, and
Matthew will pass those on to me. Carole, we did have one question.
Terrific.
That asked, I've looked at the toolkit and it is very comprehensive. Where do you think the biggest disconnect is with employers designing their benefit plan? Is it strictly looking at cost savings for something else?
I think it's really about knowing the right questions to ask their PBMs and their insurance companies, because they're going to be told, we've saved you X dollars last year, but they might not tell them how they saved that. And if they saved that money by having their employees not fill their prescriptions or become non-adherent, they're going to probably see a spike on their medical side. So it's really about asking the right questions, understanding some of these really unintended consequences, and looking at, again, how to better balance things. Where can you use prior authorization? Where does it make sense? It might make sense if there's a drug that everybody knows is overprescribed, and it's really, it's not a drug that treats a chronic condition, and it's often overprescribed. Well, that's a place where prior authorization can make a lot of sense, or if it's a very dangerous drug. But, when you're talking about having prior authorization for a chemotherapy agent, well, nobody takes chemotherapy pills because they just, think that's going to be fun. So, you have to think about what's the logic there. Why would you put a roadblock in the way of somebody being able to access their chemotherapy drug? Why would you want to have a very high copay for somebody who has to take chemotherapy? And so it's things like that. Why is the PBM not offering the generic version of a drug? Very often, if there's only a brand name, that's going to cost your employees a lot more. It's going to cost you a lot more. And if there's a good generic out there, that's a win-win for everyone. So it's really about asking different questions, knowing how these things work, knowing the right vocabulary, and demanding accountability and answers from your PBM and from your consultants and your insurance companies. I will invite you to please go visit the toolkit on the CancerCare website. You can access it directly at betterrxbenefits.org. If you have a cell phone and you want to scan that QR code, it'll take you to a form to request a full briefing on the toolkit. And you can either download it or you can read it online.